So yeah, this was in a review that in 2018. So yes, I changed my mind about that a contained leak cavity should be present when you do endoscopic internal drainage, but you can see that there are advantages and disadvantages of each procedure, and you really have to be flexible in using each of one. Endovacuum therapy, I won't talk about it much because I really don't like it. I know this is against many of the expert views right now, and it could be due to the type of cases that I see. I know endovacuum therapy is excellent in patients who have mediastinal leaks, because if you have, in the thorax you have the negative pressure, so if you put a pigtail, it won't help, it won't drain any leak cavity, so it's excellent in these positions, in these situations. But there are problems with this, and I think, at least for my patients in my country, it's not very useful or suitable or acceptable. Patients need several sessions. They say 4 to 5. I say in many patients like 6 or 7 sessions. You have to have the patient on continuous suction. If you want to send him home, you have to find him this portable suction, and it gets blocked every day, and it's really not helpful. The patient should be on NJ feeding, but in certain situations it does help. I'm not an expert on it. Some people do it more than me, but I'm not really a big fan of it. Vascular plugs have been a gadget. Many people have vouched for it. I think there is a huge publication bias favoring it. I don't think they're that successful. This is one case that we did that was successful in a chronic leak. So you see this is the gastric sleeve. This is a complex leak outside the stomach. So we used this catheter to put the vascular plug. So yeah, this is the vascular plug in place, and below here this is the lumen. And of course, it's not a one-time fix. It takes time, okay? Because it takes time for the tissues to grow on this mesh. So in 1 week, you see here that there's still an area around it that's still leaking. These patients do need a feeding jejunostomy. But at week 5, we find that, yes, things that have actually closed. And you can see here that it successfully closed completely, but I would say the success rate with these plugs is about maybe 30 to 40%, so don't be really swayed by the publications of a nice small case series. This is one study that I was glad to join. It showed something very important, that the success rate in healing a fistula by endoscopic procedures usually plateaus after the 4th or 5th technique. So yes, I do say persist with the patient, but really after the 3rd or 4th trial of endoscopy, you have to be frank with the patient, you have to involve the surgeon, you have to consider that you probably won't have much success doing any further things. Now for leaks, there is the fine print. I have to say this because many people come to conferences and they see these nice endoscopic pictures of before and after, and leaks have healed and so on. But this is not the reality. In the reality, this is the type of patient that you have when you first see, with all his comorbidities and difficult endoscopies, difficult position to work. And the patient, there is a chance that you will lose the patient. It's really a very stressful situation. When you have this patient, you know that for the coming 6-8 weeks at least, you will be woke up in the middle of the night. Even when you send these patients home with this massive stent inside, you just don't tell him, come to the ER. I give him my phone number if you have something, because he can have a perforation, he can have major bleeding. So you will be with this patient for several weeks. Not only the patient, we have the patient family, okay? They're not always as friendly. I'm talking to you from our experience in my country at least. No matter how much you explain to them that we're doing something that cannot work, after several trials and weeks, they become frustrated, and it's something that you have to handle. It all adds to the stress you have. Medical legalities are immense in this, especially if you're in a situation or in a country where there's no much real protection of you. You have to be very careful, and no matter how much you do consents, sometimes things can go wrong, and sometimes you can fall into legal issues, so you have to have this in mind. The financial issues are a big problem. Almost all these patients, they are self-funded, so many of them, they don't have the money to pay for the complication. They don't have the money to pay for the stent. They already paid everything for the surgery. So you have to have this in mind, who will pay for this. So it's a huge thing you have to keep in mind. It's not all just a glory and putting a stent and going away, so just keep this in mind. Rapidly, okay, strictures, kinks, and twists, they are another problem. The main thing is, of course, the balloon dilatation. This is the standard, and I think this will be addressed in other sessions more clearly, I just want to show something that may be a little bit different than the standard balloon dilatations, which is doing the tunnel stricturotomy. And this I find very useful because these are usually very hard to treat strictures. This is a nice video I borrowed from my friend Diogo in Brazil. I think they're the ones who started this technique. So basically, you do, as if you're doing a G-poem, you do a submucosal tunnel. And the aim is that you want to reach this area and you want to cut the muscle or even through the whole thickness. So yeah, once you expose this and you're going just beside the suture line, you then remove the muscle and then you close the entry site, either with suturing or with basic clips. This is what we do. We don't have available the clips. So this is an example of a patient with a sleeve gastrectomy who had a very tight stricture and kink. So here we start just about 3 centimeters above the incisura. We do this bleb like you do a G-poem or a poem, and then you do the submucosal tunnel. Of course, it's much difficult than a G-poem. You have the fibrosis of the suture line just beside you. So the suture line is just on my right side, and I'm tunneling just beside it. And you have the tight angulation also. So yeah, once you do the tunnel, you start dissecting through the muscle. You see the intense fibrosis now because of the suturing. Now when I do this, I do it, initially we try to be careful not to pierce the serosa. You can see the serosa here, but now I think it really doesn't make a difference as long as you actually close your entry site very well. So here we're doing the stricturotomy. You're cutting the muscle with the fibrosis. So you see here now we're full thickness. Of course, this is done using CO2. And after a while, you can see the liver edge outside. There's some omental fat. There is the liver edge. So we're happy we had now a full thickness here, and you finish the procedure by closing in, and here we did with clips. We closed the whole entry site. The patient does well, and when we see this patient, just after a few weeks, you find now that the passage is now widely open and the clips are in place. So I think it's a very useful technique. This is another patient who had a sleeve gastrectomy, had persistent vomiting and hypokalemia. Gastric scintigraphy revealed markedly delayed emptying, and you can see here why. She has severe pylorospasm. And the antrum is actually very, very tight. So you see we can't pass through the pylorus due to the severe pylorospasm. So what we did here is we did a G-poem. So the G-poem with the aim to open the pyloric ring. So we do about 5 centimeters more proximally, and of course it's a bit tight. You do the injection, and you start the tunneling. Here, of course, the mucosa is on the right, the muscle is on the left. Here we're in the tunnel. Here we use this insulated tip knife to cut the pyloric ring, which is this rim on the left. And after we cut it completely, we go out to have a look. And now you can see that we enter through the pylorus easily into the duodenum. It's an easy passage. And this patient had a remarkable improvement of her symptoms. See, this is the tunnel, and this is the entry into the through the pylorus, which is now open and passes the endoscope easily. So in conclusion, my take-home message is, for leaks, you really have to be patient. It is the most important virtue. We have many endoscopic techniques. They are not competing. You cannot be fixed to one technique. You say, I love stent or I love endoscopic internal drainage. They are complementary. You have to have an open mind. You can even be innovative because these are not standardized. In many patients, you have to innovate your own techniques. There is a room now for third space endoscopy to help with many complications. And really, bariatric complications, it's a very stressful field. It has its problems, so just tread carefully. Thank you very much.
Thanks.